Newcastle, Australia. My name is Neil Canford, and I'll be facilitating today's session of the neonatal lecture series. Circulatory disturbances occur commonly in neonates. Sometimes these disturbances can lead to serious or even catastrophic clinical outcomes. There is an ocean of information on this topic out there, but what we need is a clear, tailored approach based on understanding of cardiovascular pathophysiology and current evidence. Today's talk highlights the importance of precision-based cardiovascular support to infants in the NICU to improve clinical outcomes. The speaker of today's talk is none other than Associate Professor Koert de Waal. Koert is a neonatologist trained in the Netherlands. He completed a PhD in central blood flow measurements at the University of Amsterdam. Currently, Koert works as a staff specialist at the John Hunter Children's Hospital and is also affiliated to the University of Newcastle, Australia. He's a busy clinical researcher and a very widely known expert in neonatal hemodynamics and use of novel ultrasound techniques. Today, Koert will discuss with us his thoughts on using inotropes in the NICU and the evidence supporting them. Over to you, Koert.
Thank you, Neil Ken. Thank you for this introduction. And this talk and this title actually comes from one of Neil Ken's papers, which he wrote a couple of years back, where we started to collect this knowledge about inotropes. And a couple of the questions which I'm going to discuss today will come up. As you can see, they came up back then, and hopefully we have a little bit more information nowadays where we can talk about. Can you see my slides? Is that okay?
Yes, Koert, we can.
Oh, perfect. Okay. All right. So the title is, which inotrope, when, why, and when we started that sort of review paper, the first was the problem with the word inotropes, because there's a bit of inconsistent and confusing terminology. I'm going to go to what we know about how they work in newborns, about clinical efficacy, and most importantly, are we actually targeting the appropriate pathophysiology, and how would we know? So the confusing or inconsistent terminology has to do with the fact that, inotropes predominantly work on the heart, but they also work a little bit on the vessels. And then you have vasopressors, the name says it should work predominantly on the vessels, but they actually also work on the heart. And then you have inodilators, which we sort of categorize in that same sort of group where, so thinking about these names differently would make it complex to talk about it, and so I rather talk about cardiovascular medications than those individual sort of drugs. What do they do? What do cardiovascular medications do, and how they work? Well, they work by stimulation or inhibition, but mostly stimulation of receptors in the heart and in the vessels. And we know alpha, beta, dopaminergic, vasopressin, but there are many others. We know quite a lot about adrenoreceptors, and these come from, your basic sort of guidance books or online, where we have, the sympathetic nerve stimulated through usually noradrenaline and alpha receptors, leading to contraction in the smooth muscle or increased cardiac contractility to beta 1 and beta 2 in the heart. However, though, when we get these tables which people present, and this was from Saab Noor, it is about 12 years ago. And I highlighted the word estimated receptor stimulatory effects because this data is not that well known, it's not that well tested, particularly not in actual newborns. In animals, yes, but in newborns, I think this table and the word estimate is certainly true. And that's because we deal with, such a wide variety in babies. We have the term baby on the left, which is really sick in this particular picture. And we have the preterm baby, which we can, catch at very early age or at later age when they have cardiovascular compromise. And what do we know actually about adrenoreceptors in newborns? That there is no clinical data, and there is a little bit of animal data. This was a beautiful study done in Melbourne, which looked at the alpha 1A, the beta 1 and the beta 2 in the left and the right ventricle. And then they compared sort of, over time and with different sort of groups of baby. And this, so the baseline, you can see the baseline is set to the left ventricle as being 1. And you can see that the right ventricle has less of these particular receptors. But then when you add what they measured in preterm infants, either with or without antenatal glucocorticosteroids, you can see that the receptor density is changed or is very different. And there was some very interesting sort of findings, particularly in the left ventricle with glucosteroids, that level was much lower on the alpha 1A receptor than anywhere else, and also on the beta ones with or without. There is a couple of more data which we can read from in this particular paper. Describes the development and the expression and the activity of adrenoreceptors and how they can be affected. And this is all animal data. It depends on gestational age, postnatal age, and I showed you whether or not there was antenatal steroids given, and also on the degree and the duration of stimulation, either up and down, and other factors such as hypoxia and acidosis. So knowing that we don't know much about the adrenoreceptors and how medications then supposed to work, let's go into a more easier question. What do we actually know about the clinical efficacy of cardiovascular medication? And I think this picture sums it up. We do know a lot, and a lot of studies have been done in this particular clinical scenario, transitional hypotension in preterm infants. This is an old study from 1990, which already in detail describes the blood pressure changes over the first 48 hours of life. And there was a clear difference between the preterm infants which were sick or very immature, which is in red, compared to the babies which are well and have a normal sort of pathway in that first 48 hours. The sick and immature sort of stabilize, get a drop in blood pressure before they come back up. Later on in the 2000s, Nick Evans and Martin Kluko, my mentors, described, well, wait a minute, blood pressure is cardiac output times systemic vascular resistance. So we need to gather some data about cardiac output to get a better understanding about these relationships. And they found, of course, as expected, a significant relationship between blood flow and vascular resistance, where there are babies with normal flow and there are babies with very low flow and very high vascular resistance, which will, of course, respond differently to different kinds of medications. This concept has been further developed and more studies have been produced around the world, which all showed sort of similar ideas about low blood flow and low blood pressure during the transition. Whether it is low flow or low pressure or both, there was this ischemia period, usually 6 to 12 hours after birth, before the blood flow and the blood pressure came back up. And that particular ischemia reperfusion model was significantly associated with the development of IVHs. So this is an important concept that we learned about that time by measuring blood flow and blood pressure. There also was an increasing understanding of how that occurred. The babies changed from a low intrauterine vascular resistance to a higher extrauterine vascular resistance if you then have an immature or sick myocardium combined with shunts of blood out of the systemic circulation, early PDA left to right shunt, and the addition of positive interthoracic pressure ventilation. There was a rather high risk of developing low systemic blood flow or low blood pressure. This is where most of our randomized trials come from. There are 16 randomized trials. I think there are now 17, about 800 preterm infants. It was done with dopamine, dobutamine, epinephrine, fluid boluses, albumin, and later on with milrinone, hydrocortisone, and vasopressin. The results, though, were rather disappointing. The survival without morbidity was either no different or increased with hypotension treatment and maybe some improvement with low blood flow treatment. But the comment is predominantly on these studies. These were done mostly in an era where we intubated and ventilated almost every baby less than 28 weeks gestation. At that time, the babies with the low blood flow, low blood pressure was about 1 in 3. And the recent HIP trial from Ireland and the UK had to be stopped because actually there was no longer 30% risk of that development. It was only 1 in 10. What we have learned over time, and this is from David Osborne, his PhD, looking at the clinical efficacy of dopamine and dobutamine, whether there was a change in blood pressure on the left or a change in blood flow on the right. And you can see that dopamine is better in changing or increasing blood pressure, and dobutamine is better in increasing blood flow. But I think if you look carefully, you can also see there's quite a big overlap between those two medications. What we have learned over time instead of treating low blood flow and treating low blood pressure, we have worked on preventing low blood pressure and low blood flow of even occurring. And some of these changes were actually relatively simple. Delayed cord clamping changes that sudden change in vascular resistance. There's improved antenatal care and babies are born in better condition. And we don't intubate and ventilate all these babies anymore. We put surfactant in there and put babies on CPAP in higher and higher numbers, which reduce the risk of even developing these abnormalities. There are other cardiovascular randomized controlled trials in newborns. There are quite a lot on the topic of PPHN, pulmonary hypertension, particularly nitric oxide. Many randomized trials in term and preterm infants. And there are some smaller trials with either milrinone, sildenafil, vasopressin, and bosentan. The comment is, though, that these were targeting hypoxia, which is, of course, and I will explain that in a moment, is part of cardiovascular compromise, but certainly not the predominant part. So they were not really targeting, or most of these studies were not really targeting cardiovascular dysfunction, or they hadn't measured it during those trials. There are surprisingly little trials in sepsis. There's one new one out, which is an interesting read, but the old trials were targeting cold shock with low blood flow predominantly. There are also very minimal amount of trials in birth asphyxia, one with hydrocortisone and one with milrinone. Mostly small observational trials, and in not all of them cardiac function was actually measured, just blood pressure was measured. So this is a summary, and I could probably put all the randomized trials just readable on one slide, which are using cardiovascular medication to target cardiovascular dysfunction in these babies. They're mostly more than 20-year-olds. So there is limited useful randomized data which we can apply in our current era of neonatal care. And thinking about these babies, this is a diverse group of babies and neonatal diseases which are associated with cardiovascular dysfunction. So I think it's very unlikely to get new answers from new randomized trials. Grouping all these babies together just for the sake of sample size is probably not going to be very helpful. So we need to think about other ways of dealing with this common and significant problem. And alternative trials would be individualized pathophysiological treatment. So sort of back to the drawing board. Back to the drawing board means ask yourself the question, who needs cardiovascular medications? Well, those are the newborns with impaired perfusion due to insufficient cardiac function and or altered vascular tone. And we see this clinically as hypotension, shock, poor perfusion, acidosis, and or hypoxia. So to understand that, let's go back to the physiology, and some of these slides you will certainly seen come by and seen before in other aspects of cardiovascular function where I talk about, but this is definitely one of my favorites, where cardiovascular function is summarized in one slide: preload, contractility, and afterload through cardiac function to myocardial fiber shortening, ventricular shape and size, delivering a stroke volume. That with heart rate is the cardiac output, and then the combination, and that's a really important combination, with peripheral vascular resistance drives arterial pressure. And then, of course, it goes back into vascular volume to either be part of the preload or the arterial pressure as part of the afterload. And this is individual for the left side of the heart and the right side of the heart. Going more specifically in vascular function, which is a really important contribution to cardiovascular dysfunction. We know that it can be controlled by your autonomic nervous system on the short term and what your kidneys on the longer term. And it delivers these important components which came back up sort of through the slide in that previous slide, which is one, pressure, which we call afterload, is not completely the same, but I think it's reasonable to think about it that way. And on the other end, volume, which we call preload, again, in some scenarios that might not be beneficial. So let's talk about these two. Preload and intravascular volume are very nicely connected together. Here is a schematic representation that the venous system is this big vessel, and if it's filled, it has a pressure, which is called the mean circulatory filling pressure. It's filled to the arterial system and is connected to the right atrium with something we call central venous pressure. You can divide that vessel by putting this opening tube, which you can control with your nervous system up and down. And anything that's underneath this opening tube is actually not pressure generating. It's volume which is there, which can be recruited in times of need. But anything above it is pressure generating and is part of your preload. If we translate it in clinical scenarios, though, then it becomes a bit complex. If we look at the normal scenario where the stress volume and the unstressed volume are nicely divided, we know what happens during absolute hypovolemia, but it's hard to determine how much of that unstressed volume is actually being recruited by the body and during disease. And the scenario we very commonly actually encounter in neonatology is a relative hypovolemia. The vessels are dilated, there is less vascular resistance, and it's a bit unclear how much of that unstressed volume can be recruited to become stress volume and be part of your preload. So we talked about preload volume and the relationship between intravascular volume status. And we go to another aspect, which is afterload. And again, this is a complex sort of physiological concept which needs a bit of thought. What we know about afterload is that if you look on the left side, there's a huge difference between how the heart responds to afterload, whether you're the left ventricle, which is the blue pressure volume curve, or whether you're the right ventricle, which is the red pressure volume curve. Those lines are the dotted lines I drew in there. That's actually called arterial elastance, the pressure volume relationship at end systole, which is the definition of afterload. And you can change that with different kind of pressures. If you have higher pressure, it will go up. And then, of course, your stroke volume, that sort of distance between end systolic volume and diastolic volume, will become smaller. So there will be less stroke volume coming out. But as you can see, if you would change that pressure in the right ventricle, which is pulmonary hypertension, for instance, then the change will be way more significant. And that's sort of the summary which you can see on the right, where if you increase the pressure and then the response of the right ventricle with that percentage drop in stroke volume will be way more pronounced than you could see of the left ventricle. And on top of that, we also know that, for instance, a term baby can handle this a little bit better than a preterm baby. We discussed preload and afterload, and the whole sort of cardiovascular system, but it's not finished there. It has to go to the organs. And for that, you have your oxygen delivery and the concepts of oxygen delivery. I found this picture quite hilarious, the oxygen choo-choo train, where the important concept of hemoglobin binding and hemoglobin sort of letting go at cellular level is of importance. And when we come to that sort of local tissue, there is local control. Tissue cells itself release sort of vasodilating factors depending on their metabolism. If they have a high metabolism, they tell to the vessels around them, get a little bit wider so we can have more blood flow. And the removal rate of those tissues is proportional to blood flow. So this is for the general sort of local vascular control. But then we have organ-specific control. We know in the brain, and this is an example of the brain, and these are the vessels are sort of located in the brain, that they have cerebral autoregulation, which works on different aspects and different areas within the brain, at least to maintain this sort of stable mean arterial blood pressure, depending on how much flows goes through it. And this, for instance, and I do another example here, is very different than in the kidneys. The kidneys receive way more blood than they would require for their own metabolism. They have a filtering function. So renal autoregulation, which is again another sort of type of organ-specific control, is way more detailed and way more different than you could see in the brain. And for us as clinicians, that's particularly as an intensivist, that's really important. This study from Reed, this is an intensivist, is a really important study. It shows the cerebral perfusion pressure versus flow on the left and the renal perfusion pressure versus flow on the right. These were piglets. It is a hemorrhagic model, so they dropped more and more volume out of these little piglets, and they did laser Doppler flow in the tissues and in the organs. And what you can see here, particularly if you would drop a similar amount of perfusion pressure in the brain, then actually the amount of flow going to it would probably not be changed that much. But if you do a similar amount of drop in perfusion pressure in the kidneys, you see a significant decrease in flow. And this for us as intensivists, I think is really important to understand that the kidneys are highly sensitive to pressure changes, while the brain is more sensitive to volume changes, which can maybe alter the way you treat these particular groups of babies. We talked about preload, afterload, oxygen delivery, and then these local tissue control and organ-specific control. But then we have our diseases. And our diseases, they can target specific aspects and different levels at different sizes and at different locations. And from that point on, the problems start. For instance, tachycardia, of course, is an abnormality in heart rate, but it will change your left ventricular shape and shape and your myocardial fiber shortening and will affect preload and afterload sort of in a backwards fashion. And this goes around for every little diseases. And then think about our treatment. This is how I've been trained in using cardiovascular medication. Hypotension and shock, all group them into one sort of category. Do volume expansion. If that doesn't work, start dopamine, ramp it up. If that doesn't work, add dobutamine, ramp it up. If that doesn't work, add adrenaline and ramp it up. And somewhere along the line and a long time, hydrocortisone was added in earlier and earlier in practice. And of course, when you understand the physiology and review that physiology, this is probably not the way to go. We need a novel approach. We need to think about this differently. We need to look about this differently. And I think we can do that by individualized targeted treatment. And now there is some evidence around which I will show you that these targeted cardiovascular treatments improve outcomes. Cardiovascular treatment starts with cardiovascular assessment. And I really like this slide. It is very busy. But it is the lower point is the decision moment to either start treatment or withhold treatment or increase treatments. And if you can see the amount of boxes which are drawn here from laboratory tests, clinical evaluation, demographics and risk factors, conventional monitoring, and added circulatory assessments, you can come to this clinician's analysis and intuition to finally make this decision. And I think it is this complex in a lot of our sick babies who have cardiovascular compromise. So let's start. I'm going to highlight some of them, certainly not all of them. I will highlight blood pressure, lactate, and of course, ultrasound to see how they can assess and help into these cardiovascular assessments. This is a survey which was done in Europe to ask intensivists. These were neonatologists, pretty sure, which proxy parameter of cellular metabolism do you use into your decision-making process? And the number one, and I think that is quite common, would be blood pressure, capillary refill time, urine output, heart rate, the color of the periphery's basic says lactate, pH, movements or neurological status, warmth, and lactate clearance, which was pretty low on this particular low, and hemoglobin. So I said I'm going to pick just a couple of them in the sake of time to see what we can do with them and how we can improve in using these proxy parameters of cellular metabolism. Blood pressure is number one. And this paper from Janice Dion is an absolute beautiful paper which describes sort of how we measure blood pressure, how best to do it, how to do it optimally, and what kind of values and how that can be interpreted and affected by different aspects of it. Most of it, we measure the amplitude of the oscillations within the arterial wall with the Dynamap sort of system, where you can see in the picture on the right, when blood flows in systole, it expands the vessels, and then it comes back by elastic recoil, and that's expansion and recoil, which is measured within amplitudes, which gives us our number of systolic and diastolic blood pressure. But what's important, I think, about this, and I think where we can certainly improve, is that we need to respect this blood pressure. Blood pressure is not mean arterial blood pressure. Blood pressure is systolic blood pressure, diastolic blood pressure, and pulse pressure. Those three components are really important. Let's go to the physiology of blood pressure. This will be one of those typical sort of blood pressure traces, which you can see if you look very meticulously on your arterial blood pressure curve. And we know that if you would stop the whole circulation, that is the lowest pressure within the vessels, which is the mean circulatory filling pressure. We hope, of course, to never be able to get there, but it is an important concept. Systolic blood pressure, the peak which has been achieved, has three components or derivatives which determine that number. One is the stretch of the arteries. The second is the kinetic energy in stroke volume, that little bowl of volume which goes to your vessels, that has energy into it which is derived from cardiac function. And then the last one is the total resistance of the vessels itself. Diastolic blood pressure is very different. It's actually determined predominantly by the total resistance in the blood vessels itself, then a little bit by that recoil energy, which is in newborns much higher than it is in older age, and time. Heart rate is an important component of blood pressure as well. And last, we have the difference between systolic and diastolic pressure, which is the pulse pressure. Schematically, and looking at what determines systolic and diastolic blood pressure, you can already see that systolic blood pressure tells you something different than diastolic blood pressure. Systolic blood pressure has the added component of cardiac function to it, and therefore can tell you something different, while diastolic blood pressure is predominantly total resistance and tells you more about the vascular function. It is related to heart rate, and heart rate is predominantly related to diastolic blood pressure. If you would halve your heart rate, there is more time to change to that mean circulatory filling pressure, therefore deriving a lower diastolic blood pressure. This goes two ways. If you have tachycardia, you will have a higher diastolic blood pressure. And remember that mean arterial pressure is 2 times diastolic blood pressure and 1 times systolic blood pressure. So it also increases your mean blood pressure, which gives maybe sort of false reassurance of what might be going on in that baby and its cardiovascular dysfunction. So blood pressure and the established rule of mean blood pressure less than gestation weight is one not supported by any evidence and is something I think we need to let go. I think you need to make your own tables where you describe the lowest acceptable systolic and diastolic blood pressure. Unfortunately, as you could see at the very first slide, it changes with postnatal age, it changes per gestational age group. So you do have to have a lot of tables to give you some sort of idea what is a normal blood pressure. After the gestational age, I think we can focus a bit more on the recognition of hypotension. This is a trace of one of our babies in 2023, where the blood pressure was 58/26 at the beginning of this trace. What I try to do in clinical practice is to diagnose hypertension by looking at the percentage of change to what was normal sort of the day before. And if you make this sort of straight line to it, you can see where the hypotension started in this particular case. It went from 58 to 48 in absolute blood pressure, but probably the mean blood pressure in this particular scenario would still be above gestational age for this particular baby. This was a preterm baby. but it's a 17% decrease. And what we do, because we fare so much on that mean blood pressure and don't look at those specific changes in maybe in numbers, but not in percentage, then we start our treatment actually relatively late. The baby received a fluid bolus when the blood pressure was 27% lower than it originally was, which is actually quite significant. So the focus with blood pressure and using blood pressure is to earlier recognition of hypotension. This is a study we did retrospectively and would highly recommend that you repeat it in your own center, where we looked at 25 preterm infants with septic shock, which means they had sepsis, culture proven, and received vasopressors during their stay. And we look back at when the signs begin, when the blood culture was taken at the first fluid bolus, and if you at the start of vasopressors. And probably that was the most amazing one, that at start of vasopressors, the baby were already 12 hours into their disease, and the blood pressure had changed to 42%, which is quite significant. The second aspect I want to bring up is lactate. I think there's a lot of misinterpretations, and there is a lot of new data to show us a bit about how we can use lactate a bit better. And lactate was first presented in the 1700s. And we knew that if you did some exercise, your lactate will go over the lactate steady state. Your lactate will rise into your blood, and you can measure that and you can feel it. But as long as you stayed under that lactate steady state, that lactate should be quite stable. There is an increasing understanding that lactate is not only bad. Lactate is actually an energy source, a gluconeogenic precursor, and can be used as a signaling molecule, particularly between the brain and the gut. Simplified how the lactate shuttle works is shown in this particular picture, where we have a glycolytic metabolism. They produce lactate, which is actually good lactate. And you have oxidative metabolism, where if you're then starting to produce lactate, means you don't have enough oxygen in your blood. And that's the old classic concept, which is the bad lactate. But both of them go into the blood, and actually the cell which is, making lactate due to its oxidative metabolism, but doesn't have enough oxygen, still needs it as a gluconeogenic precursor, and that's called the lactate shuttle. So basically what this describes is that all the lactate in your blood is not always bad lactate. And interestingly, you must have all recognized and realized that there's this little peak of lactate, usually between 4 and 18 hours of birth, particularly in the sicker of babies or in the very preterm babies. And this is, of course, the transition from fetus to newborn. The fetus has glycolytic metabolism, and it has to change to oxidative metabolism, and that takes an increasing amount of lactate coming in, an increasing requirement of having a lactate shuttle. The other concept about lactate is, I think, probably more important than lactate itself, is lactate clearance. Lactate has to be sort of taken away. And just for a realization, in babies with HIE, for instance, they often have a poor liver function, so also a poor lactate clearance. And that lactate clearance in particularly disease states, particularly sepsis, is associated with poor outcomes. Better lactate clearance is improving outcome. Here are 3 examples of other sort of methods of cardiovascular dysfunction assessments: NIRS, impedance cardiography, heart rate variability. Now, when you use this particular things in your clinic, I'm pretty sure you are much into cardiovascular dysfunction. But I think that this is the tool, or the tool which is most required, is ultrasound. This is just a comedy graph of 2 divers. I did diving again a couple of months back, where underwater you have to make this OK sign while you're looking at your instructor or your buddies, but you basically have no idea what's happening in the background. And that's the same with neonatal hemodynamics without ultrasound. It is best guess physiology, which can be very wrong or difficult to guess that right. Assessment with ultrasound can happen at different levels. And in the Australian system, the Most of it is actually using stroke volume and cardiac output to measure blood flows and gives you some indication of in that particular cardiophysiology where you're at. You can add some measurements looking at ventricular size and shapes and see how they produce, or you can add some even more sort of complex and more interesting measures looking at velocities and tissue Doppler and strain to get that full picture using multimodalities and multi-parameters in assessing cardiovascular dysfunction. When you assess your cardiovascular dysfunction, you're basically diagnosing physiology or pathophysiology state. And that would allow you to target the treatment. But importantly, and we should certainly take this into the discussion segment, you should set yourself a treatment goal, and which one that is can be complex. You monitor response, and not always everybody responds in the same way, even though everything seems to be aligned. There will always be babies who are different. Then you adjust your treatments and try something different. I find that a sick newborn, particularly when you first get him and you have to assess him, you do a certain set of treatments, then you have to assess him again, either because they respond so well or they don't respond. Those are the two scenarios which you can run into, and both of them are equally important to adjust treatments. Combined clinical and ultrasound assessment provides insight into your actual hemodynamics and pathophysiology. It helps you rationalize your differential diagnosis. It allows for targeted cardiovascular treatment, and you can evaluate response if you set yourself one of the goals within that cardiovascular dysfunction. For instance, I want to improve blood flows. Individualized targeted treatment starts with any scenario of clinical shock. You do your full assessments in that picture with all the different sort of boxes into it, and you add ultrasound. This is a very simple example of how it can help on a very, very simple level with point of care ultrasound. If you have very high blood flow, then there is more likely to be a warm shock. Low blood pressure and low systemic vascular resistance where would most likely respond to a vasopressor. Well, if you would have very low blood flow, you're more likely to have cold shock with low cardiac output, which will more likely respond to an inotrope. Another simple way where you can use targeted treatments is in fluid bolus therapy. This is the Frank-Starling curve with preload on the x-axis and stroke volume on the y-axis. And you can do a mini fluid challenge, give 3 mL per kilogram over 5 minutes and measure stroke volume before and after. If you're on the left side of the Frank-Starling curve, you will most likely respond with an increase in stroke volume. However, if you're on the right side of the curve, where fluid can produce harm, you will have no or minimal change in stroke volume. Very easy way to assess and target your fluid bolus therapy. When we looked at this, we found in a very small pilot data study, we're making more data, that 3 out of 4 patients which we currently prescribing fluid to are not fluid responsive, therefore creating harm. If hypervolemia is likely, the mini fluid challenge can be added to your targeted treatments approach. If you're fluid responsive, give the fluid bolus or more fluid and consider the degree of renal cardiac dysfunction. But if you're not, do not consider that fluid bolus because it might cause harm. If you go to the transition, and the transitional scenario as an example, you have hemodynamic issues like hypotension, poor perfusion, acidosis. Adding the cardiac ultrasound can give you information combined with your clinical data. Low blood pressure, low blood flow, large shunt, PPHN. And these have targeted treatments. Low blood pressure responds to a vasopressor, low blood flow to an inotrope, a large shunt with early starts of NSAIDs or other treatments, and PPHN with high pulmonary vascular resistance with nitric oxide. And the more experience you get and the more sort of detailed information you can gather from the patients, you can also target low systemic vascular resistance, high airway pressure, and its effect on cardiovascular function or volume status. So targeting treatment based on physiologies is possible with point-of-care ultrasound for some of the simple questions, some more advanced ultrasound for other questions. Coming to the choice of vasopressor of inotrope, okay, which vasopressor of inotrope still remains a question which we haven't solved. This is a survey on vasoactive medication used in septic shock. Up until sort of 10 years ago, the NICU would have dopamine and dobutamine, while other ICUs would use different medications. Dopamine has been daddy's favorite for a very, very long time because we know how well it is in increasing blood pressure, and particularly preterm infants, and with minimal or no increase in blood flow. But over the last sort of 10, 20 years, we've also found out that dopamine have a lot of unwanted effects. It suppresses your thyroid function, which can be important, particularly in states of disease. It suppresses the time you spend in cerebral autoregulation, which I think is a really important aspect, and it increases your pulmonary vascular resistance. Looking at this data and different sort of medication and the choice of vasopressor and inotrope, we have no randomized data, but we have now groups who describe what they have been using to improve outcome. I think, and I'm going to show you two studies which I think are really important. This is the Canadian groups, 2 NICUs, 10 years of retrospective data, preterm infants with acute critical illness, lots of scans, lots of patients. And they individualized their pathophysiological treatment based on different sort of effects of medication. And you can see when they were using the clinical guided treatment, dopamine and dobutamine were the most used. But when they added ultrasound treatment, they started using more other medications like noradrenaline, adrenaline, and particularly vasopressin, and some increase in milrinone, and less use of dopamine and dobutamine. And then they reported their data of what that did on mortality during the NICU stay, reduced with different sort of models of analysis and adjustments for, say, gestational age, postnatal age, and diseases. But probably the second one is even more important. Mortality less than 7 days from that treatment. So really associated with that treatment, which was started to not have a baby die from its disease. And it was significantly reduced. How did they reduce it? And I think this is very important data. Yes, in 40% the medication was started, the dose increased, sometimes no change or other changes. But I think that second one in 4 times they did a scan, they reduced the dose when the medications was stopped because it actually, great, the target was reached of cardiovascular medication, they could move on. This is a second study from Iowa in America, which looked at very, very tiny babies, 22 to 26 weeks gestation, most on mechanical ventilation and on cardiovascular support. A very regimented approach very early on to do that individualized pathophysiological treatment during transition and individualized and targeted treatments. And they found that when they introduced that, which you can see in the slide here, the quarterly incidence of death and severe IVH reduced. And they recently produced the slides where they show 2024, and that trend has continued. And same as with the Canadians, I think is really important. They did it with less medication and stopping medication. And also importantly, the VIS score, that's the vasopressor inotrope score, they reduced the dose in which they used. So they used a lower dose overall in these particular babies to get a better outcome. And both groups describe that they have used medications which you might not have used before, phase or not much experience with. So I think it's important that we all start to build some new experiences with new medications. This is vasopressin. Read about it. There's quite a lot of data about what is the regular dose, what does it do, and most importantly, read about the side effects as well. Also read about the instructions before use. This is a summary I made to see how the trials presented their data in starting dose and maximum dose, but then also, and that was really an eye-opener to me, in units per kilogram per hour or micro units per kilogram per minute, which of course makes a big difference. So be mindful and careful about which paper and dose you want to try and recreate in your population. Hydrocortisone, I think, is now used by most of us early on into disease. It can increase vascular tone and vascular integrity, which I think particularly in sepsis is really important. It is some sort of way it can also increase myocardial contractility, but also important, it upregulates adrenoreceptors. And we've been using it because of Saib in his first trials at 1 milligram per kilogram every 6 to 8 hours. I've been doing that for 20 years. But only recently some papers came out, and I think that's really important. We probably can target these doses lower than we think. In the first 8 hours, the blood pressure came up equally with babies who received over 4 milligrams per kilogram per day or babies who received 1 to 3 milligram per kilogram per day. So adjust your dose to the target, and then you can maybe go with lower doses or other doses there. So with vasopressor and inotrope, in the vasopressors, over time, we feel, and lots of the users who use clinical and ultrasound targeted treatment feel that noradrenaline is preferred over dopamine, but there is no randomized data. There's one new trial out in babies with shock, which interestingly showed no difference, but not all cardiovascular data is in there. I think dopamine, particularly in high dose, should be avoided in pulmonary hypertension or the risk of pulmonary hypertension. And vasopressin is a really good additive to when there is tachycardia or catecholamine overload. You want to really reduce that vasopressor inotrope dose. In inotropes, there's now 4 or 5 studies which show that adrenaline is preferred over dopamine, but there is, for instance, no comparison with dobutamine in a randomized trial available. Target the most likely physiology, document the responses, use the correct dose, and we'll get to that in the discussion, and avoid high-dose catecholamines. So you can do that by replacing catecholamines instead of just adding and ramping it up and adding and ramping it up. You can do that by adding hydrocortisone early and the other way around. When the baby is better, wean at the earliest moment. Because you really want to avoid high-dose catecholamines. It's associated with mortality. It has an effect of diastolic function, and there is something which I will show you which is called a flow-driven pulmonary hypertension with ventilation perfusion mismatch. This is an early slide showing the use of adrenaline in very small babies with hypertension, and you can see that, you know, if you go over 1, the mortality was sort of 100% because these babies can't take that afterload. So even though you might increase the blood pressure to a reasonable number, that heart cannot cope with that. And also, this is a recent study from Daniel Rios, which really showed that if you just add and add and add, then your mortality will go up. And particularly one of the reasons might be a catecholamine overload, creating this afterload for both the right and the left ventricle. And the last one is related to just cardiac function. If your vasopressor inotrope score is high, which meaning more and more medication or higher and higher doses, your heart rate will go up. And when your heart rate goes up, the total cardiac cycle in milliseconds will be shorter, but it affects the diastolic time much more, which you can see on that lower picture, than the systolic time, which you see in the upper picture. So any kind of tachycardia, and particularly over 180, is less time to fill. And filling is an important aspect of maintaining your cardiac function. And then that flow-driven pulmonary hypertension. We know that pulmonary hypertension, increased pulmonary arterial pressure, can be due to increased pulmonary vascular resistance, the classic PPHN, which we see in cold shock, hypoxia, acidosis, which will respond to nitrogen. If there is an increase in downstream pressure, left atrium pressure, usually seen with left ventricular dysfunction, tachycardia, high afterload, which will respond to cardiovascular medication. But there's new data out there which looks at this flow-driven pulmonary hypertension. If you have really high blood flow, and this could be a main contributing factor to increasing your pulmonary arterial pressures. We see this in warm shock and inflammation, but importantly, we also see this in high-dose inotropes, and particularly in scenarios where they're not weaned after the baby got better. Individualized pathophysiological treatment, and I think this is my last slide, is about clinical information, blood flows, cardiac function, estimation of pressure, shunts, fluid status, and relationships with your urine output, pH, etc. If you have assessed that, you can target your treatment, and then you have to set yourself a treatment goal. But you use blood pressure, urine output, pH, heart rate, or lactate clearance, I think that's not completely clear yet. Monitor response, I think, is really important to find out which babies responded, and if you can just adjust your treatment. In some scenarios, weaning it, in other scenarios, either changing it because of the pathophysiology has changed, or changing it because they haven't responded yet. The treatments and how we do it and where we look at, particularly if you add ultrasound, if you have information about cardiac output and you want to improve that, well, either an inotrope or a chronotrope, dobutamine would be a good one. If you want to increase the systemic vascular resistance, we used to use dopamine, which is still a good vasopressor, but you have to be mindful about the regional perfusion on the lungs, brain, and kidneys. If you want to decrease the pulmonary arterial pressure, change the pulmonary arterial pressure S&P ratio, nitric oxide, and all these other medications we used in PPHN, but be mindful of heart-lung interactions. And then you can see there is a move for everybody, including myself, to why don't we go straight into this sort of middle factor where we have a more overlapped sort of use. They can work a little bit of cardiac output and increases SVR at the same time instead of these individual medications. So there's definitely an increased use of adrenaline and noradrenaline in a lot of centers. I highlighted the use of vasopressin, particularly in the Americas, and the use of hydrocortisone. Ultrasounds required to be part of doing this is part of the new skills to learn. And I'm, for one, think that particularly point of care, ultrasound, warm shock, cold shock, the mini fluid challenge, and other sort of relatively simple things should be part of every intensivist arsenal. Doing a more advanced sort of function takes way more skill, but beginning of just doing point of care and the basic cardiac functions is important to every intensivist. And this is my last slide. Thank you very much.
Thank you very much, Koert. That was a very, very comprehensive talk. You provided us with a fantastic insight into the cardiovascular physiology, need for multimodal inputs, and very nicely summarized the literature around the clinical management of common neonatal circulatory issues. Thank you very much again.